Hi, everyone. I am Dr. Jess Calohan, and I'm going to be moderating this session related to telehealth. What we're going to do is each of our speakers are going to have an opportunity to talk about telehealth in their respective areas, and I'd like to introduce them. And then when the speakers come on, they'll tell you a little bit more about themselves. And then get into their specific area of expertise. So we have Dr. Rachel Mack, our Associate Dean of Academic Affairs, and she'll be talking about the impact of telehealth on education and some of the things that we're doing at Frontier. And then we have Dr. Vicki Stonegale, who is one of our F&P faculty, and she'll be talking about her experiences with telehealth and F&P practice. And then we also have Martha Harvey, and she is a women's health nurse practitioner and regional clinical faculty at Frontier, and she'll be talking about women's health. And then I will wrap it up talking about the psychiatric mental health telehealth experiences and kind of what that looks like. Each speaker will present, and then there'll be about a 5-minute Q&A after their session for folks to answer any questions. Feel free to unmute yourself or post your questions in the chat, which I will be monitoring. So part of the reason why we are doing this session is because obviously with the COVID pandemic, we've seen a lot in terms of telehealth and a huge shift to telehealth, and a lot of specialties have not had a lot of experience with telehealth. And so this was uncharted territory. And interestingly enough, at Frontier, we've had the foresight about telehealth, and we've implemented some telehealth things into our curriculum and working with our students, but we really had to put our foot on the gas pedal to get those things up and running. And so clearly telehealth, we believe, is here to stay, and we're hopeful that that our panel discussion provides you with some additional insights and answers some questions that you may have about telehealth in your respective specialty practices. So with that, I'd like to turn it over to Dr. Rachel Mack, who's going to talk about telehealth and the impact on nurse practitioner education and what we're doing at Frontier.
Hi, everybody, and thank you very much, Jess. I appreciate it. So we just want to start with a little bit about me. I'm a family nurse practitioner, and I do still practice. And so I had never, didn't experience anything with telehealth before the pandemic started. And so I just assumed, I made a horrible assumption that since I worked online and I talked to patients every day, that I could do telehealth no problem, that I could jump in there, feel comfortable, and that was not the fact. I felt very uncomfortable, and it wasn't an easy situation to learn how to navigate with my patient and provide the high level of care that I wanted to. So I was really excited when Frontier, we started our conversation about how to include telehealth in the curriculum, because we know that, again, like Dr. Calohan said, this is here to stay. It's not going to go away. So we wanted to make sure that we did a really good job of threading this information across the curriculum and across all of our programs. And the first step was to identify a platform that would work for our faculty and our students. And we're just in the very early phases of getting trained on this new platform called SimIQ. And SimIQ will allow for virtual telehealth experiences for our students across all programs and across all curriculum. Another thing that we're doing is we're looking at our curriculum currently to see where does the concept of telehealth live and where does it not live, and how can we take the accreditation standards, the competencies and essentials that are associated with telehealth and thread that through our curriculum so our students are gaining the information upon entering the university. So they're being exposed to it, we hope, in our role courses, where we will first thread that information and then carry it across all of our didactic courses and in our management courses, and then throughout our clinical bound and clinical courses as well. So students have a touch point throughout the curriculum about telehealth and about those experiences. So here at Frontier Nursing University, we do utilize simulated patients for our virtual simulations, including our telehealth simulations, and our psych nurse practitioner faculty have been developing some of these simulations currently that will roll out at the beginning of the year in our new platform that we're really excited to share with our students and share with our faculty, and begin really educating our students on the telehealth experience and the new way that we're learning how to see patients in the world during this pandemic, which I think telehealth will be here to stay. So I'd be happy to answer any questions that you might have for me. You're welcome to unmute, use the chat box, whatever works best for you.
Dr. Mack, could you talk about your experience with telehealth and then how that kind of translated into the importance of it being integrated into our, or what are some lessons learned from your own experience? You mentioned that you had not used telehealth before the pandemic, and this was definitely something new. So what are some takeaways from your experiences that you feel like are a necessity for us, or things that we need to consider in our education platforms, as well as maybe even just a few words of wisdom for those folks out there that may not be using much telehealth yet?
Absolutely. I think the most important aspect is to learn how to relax and adjust to a new way of thinking and translating your care to a patient virtually. It was very difficult for me. I work in a very rural community, so one of our first challenges that we faced in the clinic was with our internet connection and doing video conferencing sessions with our patient. We had never tried before, and we found out very quickly that it did not work. So we had to resort to using FaceTime. So we were very innovative in the way that we had to start utilizing our telehealth before we could upgrade to a better internet service at the healthcare clinic. So it's really just learning how to talk to patients in a virtual environment. Like I said, I'm very comfortable working online, very comfortable talking to people online, but it was different whenever I needed to examine an abdomen or check a pulse. The things that I had to learn and how I had to teach patients how to palpate their own abdomen so I could watch their facial expression for any signs of pain or tenderness and listen to what they were saying. So I think the key takeaway for me was listening. And it was a big eye-opener for me to say, you know what? Our students really need to be prepared early on in the curriculum and learn the concepts that surround telehealth and how to really treat patients in a virtual environment before they make it to their clinical bound experience where they're simulating these activities, and before they make it to clinical where they may be working with a preceptor that's conducting telehealth visits. So increasing that comfort level, getting a little creative with the way that you examine patients, and learning and being flexible, I think is very important. When we first started out, we were telehealth only for several weeks. We started opening our clinic back and letting patients in. And when we did that, it threw a new little kink in the system, because then we were bouncing back and forth between, okay, I'm going to run down the hall and see a couple of patients. Now I've got to go back to the office because I have a few scheduled for telehealth. And trying to balance a virtual schedule and an office schedule was a little bit tricky. So we learned that we needed to space more time between our patients so we could make that smooth transition, because it always involves whether the provider can get on and then helping the patient gain access as well.
Great, thank you. Any questions from our audience? Like I said, feel free to unmute and start your video, or place it in the chat box.
All right, well, you're free to reach out via email if you have questions after the session. Thanks, everybody.
I'm sorry, I unmuted late. This is Janet. I actually have a question. Did you find that people were more responsive using telehealth or less responsive?
More responsive. They were actually engaged and interacted more via a telehealth experience than some of my patients do in person in the office. It really took a higher level of thinking and questioning from my end to gain the information and knowledge that I needed the patient to verbally express to me, since I wasn't able to use my hands and equipment.
Yeah, I found that they tend to be a little bit more chatty
They are.
via telehealth. And I think, I found that you get a little bit more, you're able to get a little bit more personal, believe it or not. I mean, you wouldn't think you would get more personalization via telehealth than via in person, but I don't know if it's just because they're not in the same room, they feel more comfortable, but that's kind of what I found. So I wanted to know if you've experienced that as well.
I have. Thank you. Great question.
Looks like Dr. Arterberry has a question for you.
Yes, Dr. Arterberry.
Yes, I'm a family nurse practitioner also. And I was wondering if or how you set up protocols for which patients would be telehealth and which ones you would not allow to be telehealth, because it seems that there would be some things that just would not work as well telehealth in the F&P world.
That's right. I found out very quickly that anything to do with looking in an ear, looking in an eye, or needing to auscultate heart sounds were not possible for me to do. I was able to really achieve a good abdomen exam via patient performing their own abdominal exam, sitting in a chair. Medication management has worked very well. Hypertension patients work very well if they have a cuff at home, but I have encountered barriers when I needed physical equipment to determine the diagnosis in which the patient was complaining.
Thank you.
Thank you. And that resorted to seeing patients in the parking lot with equipment for a while.
Dr. Mack, I have a question.
Yes.
This is Trish. And
hi, Dr. Voss.
I'm wondering about the equipment. And I think there's a couple things I'm going to kind of work on here. Some patients probably have the ability to get equipment, things like they can take their own blood pressure, et cetera, and other patients maybe don't have access or the means to do that. So I was kind of wondering if there's any kind of grant programs that you know of, or will there be such options in the future, or maybe reimbursement from insurance companies and things like that to facilitate telehealth? And then building on that, it seems like you could almost get plugins for computers eventually, where you could be able to just put something up against a pregnant woman's belly and listen to the heart tones that way, or listen to the heart and do all that kind of thing. Are you aware of anything that's being developed like that?
Absolutely. There are virtual ophthalmoscopes and virtual otoscopes and virtual stethoscopes that some of the larger clinics will actually, they can send out a nurse to the patient's home to conduct some of these exams, so the provider on the other end virtually can like see inside the eye or see inside the ear or listen to those heart sounds or bowel sounds that they're auscultating. There are a lot of grants right now for a variety of things supporting telehealth, whether it's for education or for clinics, especially in rural clinics. There are a lot of opportunities. I know that our clinic is looking at one opportunity for a rural clinic currently, just to try to get some support for us to get an actual platform and kind of move into the 21st century where we don't feel like we currently are.
All right, we have time for 2 more questions, but we will continue in the F&P vein with Dr. Stone-Gale next. So Nicole, you had a question.
Hi, Dr. Mack. Can you hear me?
I can, yes, Nicole.
It's 2 questions. First of all, you mentioned being able to become rather proficient at an abdominal exam with the patient's hands. Have you found that family members have been great substitutes for you when addressing the other patient? The mother, using her hands to assess the child's abdomen or whatever for you? Do family members step in well?
I haven't had that opportunity, but I sure wish they would. But I have not had that opportunity yet. Hopefully in the future.
And then the other question was just quickly, has there been a smooth transition in the billing world, whereas it was met with such so many barriers prior to the pandemic? Did it flow smoothly once it was necessary?
It did. We have an excellent biller, and she provided a lot of guidance for us on specific codes that we needed to use so we could get paid for our visits. And it was something new to all of us because we weren't using any of those. So we all had a learning curve just on the billing and coding side from a provider to get paid for our visits.
All right, and one last question before we move to Dr. Stone-Gale. It's from Marcina Howard. Any thoughts about using Zoom to observe students in clinical rotations, and are there any HIPAA-related issues?
So we're looking at the SimIQ platform that we've actually purchased because it does so many things for us. It will not only allow us to do telehealth visits, but it allows for scheduling of virtual simulations and really more of an organized system outside of what Zoom offers. So that was the reason that we leaned towards a platform more for, we have so many students and so many faculty, and we need a lot of rooms. I found out the hard way that I can't run 2 Zoom meetings at the same time. When we first started this venture, I set up 2 virtual simulations, but I couldn't run 2 at one time. So it was one barrier to Zoom.
And I believe also that there are some of our clinical faculty that are doing virtual visits, clinical site visits, and we've talked about what that looks like in terms of them being in the room with the patient and the preceptor. And so our credentialing folks have worked on that. And as long as we've got a contract and and we're using HIPAA compliant stuff, and generally it hasn't been something that has been a significant barrier. It's really up to the patient whether or not they want to allow that or not. Just like it would be if one of our clinical faculty did a site visit at a clinical site, wanted to sit in on an evaluation with the patient. It's really up to the patient and the preceptor. So so those are some things that we've also had to adapt to and adjust to is are there are opportunities out there like that, and I believe some of our clinical faculty have already participated in some of those types of visits. So all right, great. Thank you, Dr. Mack. Really appreciate your insights. All right, Dr. Stone-Gale, you're up next.
Okay, great. Thank you, Jess. So I am Vicki Stonegale, and I'm a family nurse practitioner. Been a family nurse practitioner for 28 years now. I hate to date myself, but I just did. And I'm also the course coordinator for Primary Care 1, which is in FNU, where this is the course that the students take when they go into the management course. So this is one of the management courses. So we've, in my primary care practice, though, I practiced in primary care in a family practice setting in Fort Lauderdale. And so we had not done Zoom. We had not done Zoom before. We had not done any type of telehealth before. So it was all of a sudden one day we were thrown into this. And luckily our electronic medical records company was able to connect us inside of their system. And they immediately got us hooked up into the system to be able to do a lot of different things with our patients. So that really helped us, but it was a big learning curve. And I think the PA in our practice had the worst time because he is not tech savvy. So he had the worst time, and he actually stayed in our office because he could not go home to work, and because his wife was working from home and they only had one computer. So he found those challenges. I was able to work from home. And the physician that works with me, he's also technically challenged. So it was a real effort to get him up and running, but we did it, and it worked out really good. But what we saw some of our challenges was making sure that we charted for legal reasons. And one of the biggest things that we did when we started our notes was to make sure that we documented that the patient was presenting to the office for a visit, for a visit on telemed using audio and video capabilities that were compatible for both the provider and for the patient, and that they gave us verbal permission to proceed with the visit. We wanted to make sure that was documented, so they gave verbal consent for the visit. And many times I would put in there that the patient was well known to the practice. And so we did not see any new patients on telemed at all. And we still are not seeing new patients if we do a telemed visit. So we really, and that was, a lot of that had to do with Medicare at the time was telling us they did not want us doing, some of the insurance companies were telling us they did not want us doing new patient visits on telemed. Well, that was a big issue because there were a lot of new patients that wanted to come in, and we just had to refer them to like an urgent care or something like that. But one of the biggest things I think that was interesting for me was the inability to do some of the things that I'm so used to doing, like physical exams in the office and pap smears in the office, and completing, just specific exams. The patients got used to taking pictures and putting them up and using, having, maybe if they had a spot on their back, they would have a family member take a picture of their back, and then they would have it on their phone and they'd put it up on the screen, and we were able to do visits that way. But that was a little bit of a challenge. And then the other thing too was the elderly patients. That was a huge challenge because if you really think about it, a lot of elderly patients are not technically tech savvy. They're technically challenged. And so what the problems were we were encompassing with them is that, and a large amount of them was they could not get on Zoom. They did not know how to get on Zoom. They didn't access it, even though, we were using our platform in the office. They would get a link and they didn't know how to get a link. And some of them didn't know how to get into that link if they did get a link. And so then we would sit there and be waiting, and we had other patients behind them. And now we're behind on the schedule because we can't get connected with the patient. So we're ended up calling the patient on their cell phone, and now the patient's got my cell phone number. So that was a big challenge because now they're calling me all the time now, and I just have to keep, looking to see who's trying to call my phone. So that was a big problem. And I found that even in some of the younger population, the connectivity was an issue. And I think that was across the country. Everybody was just being bogged down so much with internet issues that we ended up, really having some technical difficulties with cameras and sound and that type of thing. In doing some of the exams for the patients and looking at how we were documenting some of the visits, we had to document that the vital signs were not performed due to telehealth. And many of the patients had their own blood pressure cuffs, so I would tell them to take their blood pressure, and then we could discuss that. They could show me on the screen what their monitor showed. Some of them knew how to take their heart rate, abdominal exams, like Rachel was saying, skin exams, those type of things. Otherwise, you really had to go by some of the symptoms that the patient was giving you and then try to work with them and figure out what was going on. Labs was another issue. You had patients that really needed to have labs done. So what we did in our office, we had one girl in the office, one medical assistant in the office that stayed with our PA there. And we would allow one patient to come in to get blood work. So I would tell the patient, let me call the office. Let me see if they can have you come over there. And then I would call the office and say, I have Mrs. So-and-so, she needs to have this done and this done. I'm going to send her over there. And then the girls knew when she was coming. They would do temperature checks. She would come in the back door. They would draw her blood, and then she would leave, and then I could get the results and call her back. So that's kind of how we handled getting blood work done. There were some cases where patients were having some palpitations, they just weren't feeling right, and their blood pressure was a little high, and we would have them go in the office, and our PA actually would see them if he needed to see them. So we were very lucky and fortunate to have one person at least housed in the office, and he's younger. He doesn't have hypertension. He doesn't have blood pressure, or cardiac issues like, the doctor does. So he was not comfortable going in. So we did have the capability to access the office if we had to do that, but it was very rare that any of our patients would go in there. You know, they felt very personal and comfortable on telemed. You know, it's so interesting because, you know, you've over the years, you develop so many relationships with your patients. And I talk about that with all of you in Primary Care 1, but you get to know your patients after all the years. And one of my patients said to me, you know, what have you been doing? You know, when you're, you know, waiting for patients to come on, and I'm saying, well, you know, on the weekends, and I've been painting tables, and I've been doing this, and she goes, oh, show me what you've been doing. So of course I walked my computer around the house and showed her all my tables I had redone and all my little picture frames I had redone. So it was very personal. She was showing me the painting of her bedroom and the new bedspread she bought. So when Janet was talking about that personal touch, you do get that personal touch, and the patients really liked it. And I found that that connection with them was a little bit different. I didn't feel as rushed. I felt like I could talk to them more, and maybe it was because they were in their own environment and I was in my own environment, and we weren't in a sterile work environment. So I really kind of enjoyed the telemed, and I do kind of miss it too. But with the documentation, I'll flip back to that a minute. You know, we made sure to document that the patient did not appear in any distress, that they were pleasant, cooperative. The lungs, when we documented lungs, we just said, you know, that they did not appear to be short of breath. They did not appear to be in any respiratory distress. And then heart, you know, that, you know, we couldn't document heart, obviously. And we would do a general appearance, you know, no apparent distress, pleasant, cooperative, as I said, and then alert and oriented. So it was really very minimal documentation, unless you were looking at a skin lesion or you were actually, you know, having them examine something that you wanted to make sure to document. Billing was a little challenging for us at first. It took a good 2 months for us to get on track with that. We were getting reimbursed sometimes $8 for a visit, and we had to figure out how to change that billing so we could get reimbursed at a different rate. We did not realize there were telemed rates out there. And finally, I think the insurance companies and Medicare got it together enough where they could start seeing what they needed to do for these visits. And then they were starting to pass that on to the primary care providers' offices and our billers. So we had to use different codes. At first, we did not know we didn't have to use different codes. So we were just billing, you know, a regular 99214, and we didn't realize we could not bill that way. So once we got, and then we kind of got a feel for which insurance companies that we really could get, you know, that were going to pay more money. So those were some of the things that I kind of found. And we still do a little bit of telemed for some of the elderly who really don't want to come out. But now that we're back in the office, we've been back for about 6, 8, maybe about 2 months now in the office. We have patients that want to do telemed. So now you've got a telemed visit on your schedule and you're seeing patients. So if you're running behind in the room, you can't get to your telemed visit on time. So we try to book the telemed at the end of the day. So if we're running late with patients, or, you know, we're good, and then the end of the day, we can just do our telemed visits one right after the other. But they're very far and few between. Now with COVID spiking up again, we're talking about maybe doing some more virtual things with our patients again. So that's kind of where I am with telemed. As I said, I enjoyed it. I miss it a little bit, but I also miss going into the office and interacting with the staff and everything too. But I did find that comfort level with the patients and really enjoyed spending some quality time with them on camera. The only thing I didn't like was you had to do your hair all the time, you know, make sure you're, make sure you had your makeup on. So any questions at all that I can answer?
That was my problem too, doing my hair.
Yeah, right.
Any questions from the group? Can you talk about some of the policies and procedures that you all had to put in place outside of the documentation? I mean, sort of, you know, you kind of provided an overview, but were there specific things that you all had to develop? It sounds like the types of patients you were going to see, and like you said, your scheduling and things like that.
Yeah, so like I said, we didn't see any new patients. They did book us every 30 minutes with telemed visits, and you know that kind of takes a hit on your practice too, because we're used to booking every 15, but we did every half hour because we started out doing every 15 minutes. But the problem with that was people couldn't connect. So you might spend your first 10 minutes trying to get a connection, and then they can't hear you and you can't see them. And now you got to call them on the phone and, you know, all that type of thing. So, you know, we went from 15-minute visits to half-hour visits, which was not, you know, cost effective for us at all, but it was something that we had to do. We did not see, obviously we didn't, if anybody called and said they had chest pain, obviously that was not something that we saw. If they were short of breath, that was not something that we saw. So it was really more, you know, at that time, a lot of people were worried about COVID. You know, are you doing COVID testing in the office? You know, I've got a cough and a sore throat and I have a fever. And, you know, sometimes it was, what do I do? You know, I was exposed and do I need to quarantine? So there was a lot of those type of visits too. But, you know, people whose blood pressure was sky high or something, no, we didn't see them in the office. And our girls triaged them pretty well before they would put them in on a telemed visit. And then cash patients too. So that was another issue with patients paying cash. So we would not do the visit until they paid the cash up front, because if you don't, you know, if you see them and then you go to get the billing, well, they've already got their visit done and then they just don't pay the bill. So we learned that after a couple patients, that they have to pay up front. So if I saw on my schedule it was a cash patient, I had to call the office or I had to email the office and say, was this visit paid before I go in? So that was another kind of drawback that we had to look at before we saw the patient. Then we got to the point where they would put them on my schedule, but they would put cash in, already cash paid or something. So I didn't have to take my time to be calling the office.
So it sounds like some of this created some more of an administrative burden for you as the provider to kind of monitor your schedule.
It really did. It really did. And, you know, there would be times when I would look and there would be nobody on my schedule. And so I'd start my frontier work and then I'm getting so engrossed in my frontier work. And then I look and I'm like, oh my gosh, they put 3 people on my schedule and they never told me. So now they've got to text me and the doc every time they put a patient on, because we may walk away to say, oh, we don't have anybody for an hour. I'm going to go do something else. And then I see that I missed 2 visits and that people are sitting and they're waiting for me. So now we had, you know, then we had to go to text me as soon as you put a patient on my schedule with the time. So yeah, there was a lot of administrative things that had to be ironed out at first. And then we had patients that were very angry that the office was closed. They would get on telemed and they would really not be very happy that the office was closed and they had to do this, which, you know, we tried to explain to them, but yeah, a lot of paperwork stuff, a lot of things to deal with.
So one of the questions is, how did the patients pay cash? Through the office or via an app?
They paid it through the office. The girls took it, you know, through the office. They would give them their credit card number and they'd run it through there. The other thing was medication refills too. This was a big issue because controlled substances. So let's say, you know, we have a policy, very strict controlled substance policy in our office, and our patients have to be seen, you know, if they're on like Xanax or something like that, they have to be seen every 3 months. If they're on Adderall, they have to come in once a month. And so now you have these patients that, you know, you can't give certain refills for unless they're seen. So they don't want to come in. They can't come in the office, but they don't want to do telemed. And you're like, well, you got to do something because I can't fill your meds. I have to have something documented on you. And in Florida, nurse practitioners, you know, with certain controlled substances, we can't do them. So we, you know, then I have to call the physician and say, oh, I've got Mrs. So-and-so on the line and she needs this. Can you fill it for me? So now I got to, you know, I got to break my time and go in and do that. So the controlled substance thing and the medication refills were an issue. You know, as long as I could get, you know, I was able to get in the chart and see when they were there last and see when their last refills were, and I could go to eForce and verify their controlled substances. But it was also an issue of them not wanting to pay for a visit just to get medication refills. And you know, we couldn't just be giving med refills without a actual face-to-face with some of these people. So that was a big challenge too.
Absolutely. So we have time for 2 questions. First one is from Rachel. Is it possible or a good idea to function as a telehealth only provider?
I think it is. You know, I think primary care is a challenge for that. I think psych mental health, you know, absolutely. but I find it very difficult. I find it very restrictive for me in primary care. You know, with only working 1 day a week in the practice, my day consists of, my practice day outside of Frontier is they book every PAP on my day because the doc doesn't want to do them anymore, and the PA male doesn't want to do them. So I could have 7 or 8 PAPs on my schedule, and then a lot of my patients have come in for physicals. So my whole day, and I'll give you a really good example. You know, we're in South Florida, we've been flooded here, and it's still raining. I had water up to my knees in my street. I couldn't get my car out of here for 3 days. So this morning is my practice day. My husband had to actually, I said to my husband, you know, I can't get the car out tomorrow. So I'm gonna either have to take you to work and take your truck, or you're gonna have to take me to work and go into work late or something, because I had 7 PAPs and 6 physicals on my schedule. So that's a lot of money out of my practice if I would have had to call out today, and I can't do any of them on telemed. So there's a big challenge with primary care doing, you know, I think there's a place for it in primary care, but I don't think you can encompass every piece of primary care into telehealth. It's just not going to work.
Great, thank you. And then the last question before we move on to Martha is documentation of consent, where you document it in the chart, and then how often are you mentioning telehealth in the exam, in your documentation that was performed, and what the patient did in terms of palpation that Dr. Mack was talking about?
I just, you know, I document my visit. You know, a 53-year-old female patient presents to the office on telemed visit using audio and video capabilities, blah, blah, blah. And I do that, you know, as part of my subjective portion of my visit. And then during my objective portion, and you're still going to do your whole subjective portion, you know, your HPI, you know, all the way down through if you have to address certain things for episodic or whatever. But then you get to your objective section, and I would just say that, you know, the patient took their own blood pressure. This was the reading. Patient, you know, and I did write in my note, patient held up monitor so I could see the reading, and just documented that way specifically.
All right, great. Thank you very much, Dr. Stone-Gale. Appreciate it. All right. Martha, you are up next.
Hi, my name is Martha Harvey. I've been a certified nurse midwife for 30 years. And I also am OBGYN nurse practitioner, and right now, and I'm clinical faculty for the regions of Vermont, New Hampshire, Maine, upstate New York, and northern New York. So I have a whole sense of travel, and I have a whole sense of all sorts of telehealth when we first started up. You know, in March, late March, all of a sudden I was out in the western part of the state because I was doing some per diem work out there. All of a sudden we had to, like, okay, we got to start seeing patients telehealth. And it was a mostly OB practice. So quickly when we started hearing about this, how are we going to put it together? What's it going to look like? All this kind of stuff. With the OB part, ACOG came out with some decent guidelines right off at the beginning that pretty much said, you know, we really don't need to be seeing patients as often as we have in the past. Their first intake visit, we really weren't doing a physical exam then. So their new OB, we could be doing on a telehealth visit, doing all the intake, ordering whatever their prenatal labs, and setting up for when they should come in for their first visit. And then we were saying they really don't need to be seen from like 11, 13 weeks till about 20 weeks. And then when they come in, they do their anatomy, ultrasound, and then have a provider visit then. And our patients really embraced it. They were very happy not to have to come out as much. And again, I'm in upstate New York, so we heard all of everything that was going on in New York City, and everybody was in a panic about everything. So if we said, well, why don't your next visit we can do telehealth? They were more than happy to do that. And I do think some of these recommendations are going to continue through our practice from here on out, that we really didn't need to see our OB patients as much as we were. I mean, yes, towards the end of pregnancy, you really want to roll out and risk out, but I think several of these visits are totally fine to do telehealth. And like I said, they kind of appreciated it too. Many women of childbearing age, we've said they were the only ones that could come into the office. And I mean, we just went into strict guidelines again, where no partners could come in with them. They couldn't bring their children with them. So, you know, for many of them, it really is very, very convenient. That's kind of how we started off, but not without a lot of bumps in the sidewalk. Especially, we didn't, as providers, we didn't have very good control over who was put into a telehealth visit. I remember one of the first days we did it, and I had several telehealth visits, and one of them was this poor woman who didn't speak English well, and my Spanish is really bad. And, you know, she was one that really needed to have a visit, or at least we should have been connected somehow with an interpreter. Another woman had a lot of issues about where is my C-section going to be if I don't want to have a scheduled C-section, where can I VBAC, where do I have to go? So, you know, those were kind of visits that needed a little more information, that we really needed more discussion than what I could provide just over the phone. Our EMR and things were set up really quickly. Telehealth visits were based on the ICD-10 codes, and all those were all put in there, and they're all based on how many minutes you spent on the phone. So, and the first sentence, like Vicki just said, was that we said, this is a telehealth visit, patient agrees to this visit. Next time they came in, we would have them sign a consent that they were consenting to doing telehealth visits, and then it was left in their chart so that we knew that they had given consent. Way back at the beginning, I just wanted to mention one thing, is that the Health and Human Services, through Health and Human Services, if I can find, the Health and Human Service Office of Civil Rights waived Hipaa enforcement for telehealth during COVID. So what that meant was that providers, practitioners could get reimbursement, while like a nurse visit could not bill, like nurse triage visit could not bill telehealth, but any of the other people in the office could. So when we think about this in the long run, we could have been billing for so many visits that we never even thought about billing, because we were just doing phone triage, you know, at 8 o'clock at night, and filling this script or that on the weekends when we were on call. So I think that kind of was a little eye-opening experience, that we could have been doing a lot more. What we found also with some of this telehealth, with telehealth visits, especially with the postpartum women, it seemed to be a great way to connect with them, especially when, you know, they don't want to bring their newborn out in the middle of a COVID season, and they, you know, it's hard to figure out, but you could watch, especially if they were having issues with lactation, you could observe them with breastfeeding. You could look and see what their breasts looked like. You could, it was also another great way, and most insurance companies would pay for blood pressure cuffs, and to teach women how to check their blood pressure and what is normal, what's not normal, and what parameters should they be. So it's a lifelong skill that we are teaching a lot of just basic health care, and how to support themselves, and make kind of, and know what the danger signs are of when should they call. It also was a really good way to interface postpartum with using postpartum depression scales, and really following up closely with women who are having issues with postpartum mood disorder. And you could kind of get a sense on where they were living, it gave you this whole snapshot into their lives. Like Vicki was saying, you could show what you're working on, but for these younger patients, younger moms, you could hear if the partner's yelling at her in the background, there's kids screaming, running around. It gave you a whole sense of what their environment was like on a daily basis. It also, for some people, it gave them the opportunity for them to be in their own setting, so therefore they felt more comfortable and could talk to you about different things that maybe were kind of tough topics to talk about. When we're looking at, Trish mentioned earlier about listen to the heartbeat, heart sounds, so many people have their little fetal heart monitors, but especially telling women, especially over 20 weeks, every time you feel your baby move, that's a really good thing. So making them much more aware of their own body and taking more responsibility for their bodies too. It's a great way to facilitate even some support. It's another good way, especially for the OB patients, for gestational diabetes to review their blood sugars and kind of if we're tweaking insulin or doing different things of what they needed to do. Most people have a scale at home if they wanted to weigh themselves and said they're really puffy, get a sense of what their last weight was when they were in the office and then know where they are. So if they are feeling like they're putting on extra swelling and edema. Another aspect, and again, this is our, once we started doing this, we're like, oh my gosh, we could have been doing so much on telehealth. You could do a lot of your contraceptive counseling on telehealth. A lot of times women come in and want to talk about just different birth control options and things that but they don't need an exam, but they just wanted to talk about them, or even just a discussion about IUDs, and then we could set them up for the appropriate time when to come in. It's also another way to review lab monitoring. Also talk to them about STIs and how to and the follow-up needed for them. But again, the domestic violence screening, really important, especially in this COVID time right now when people are feeling pretty isolated. Again, I'm in Northern New York or upstate New York, and we're going into the 6 months of darkness, we feel. So I worry about domestic violence with young families right now. Substance abuse assessments. It's also a great opportunity to maybe talk to them about and screen and give them suggestions on smoking cessation and counseling. Also about maybe alcohol screening and counseling with them. But it's not just limited to stuff like that. When we think about other things that we can do, especially with our GYN patients that we don't think much of, but like our more mature population, we worry about falls. If you're looking at their house, you can see that they have these scatter rugs all over and they have 3 cats that are running around like crazy, that you can address some of those issues that you may not think about when they're in the office with you. You can talk to them about healthy diets and exercise. Again, for the mature women, which right now I'm doing just the 1 day a week in my local prime care office doing just GYN, but following up on urinary incontinence screening and types of things like that. If they've had a new risk of someone in their family was diagnosed with breast cancer and they have all sorts of questions about BRCA testing, you can do all of these things on telehealth. So I think what it has shown is that, it's a lot of people are really engaged in it and appreciate not having to get out and appreciate not having to, fight for parking in different places. Again, I'm in a place where I'm not too worried about parking. And it can be done through phone. It can be done through an internet service, a Zoom type of thing. So whatever way works for you. Main kind of thing is the education piece and setting it up so that the appropriate patients are in telehealth and that you're not seeing patients that you really needed to put hands on and you really needed to see. But again, nothing's ever written in stone and you can take that back a little bit. The one other thing I do want to mention that we brought up just quickly is I also am regional clinical faculty, and there were questions earlier about Zoom and virtual site visits. I do virtual site visits, or sometimes I call them sort of hybrid visits. I'm not seeing patients because most people in their offices do not want their patients exposed to any extra personnel than they have to. So this is kind of how I've been doing it lately, is have the student bring in their laptop, I connect to them with Zoom. I usually will say, why don't we connect at 10 o'clock? So maybe they've been in the office since about 8:30, 9 o'clock. I had them review a couple patients that they saw that morning and reviewed their management, gave me a nice little S-bar, just kind of figured out, we kind of talked it through, and then have them go see a patient, and their preceptor can sit and visit with you on Zoom. And then when they come back, they can present the patient to the preceptor and myself and, kind of discuss it, and then go in and see the patient together and then make their management plan. It seems to have worked really well. A couple sites will let me be there, like in the midwife's office. I'll sit in their office and just listen to them the same sort of way. I even sat last summer outside on the picnic bench, on a picnic table, listening while she went in to see the patient. I sat out there with the preceptor, and then she came back out and gave me, so they had good Wi-Fi. I could even get it on the picnic table. So I think it's, don't sell ourselves short on telehealth, because I think it's a way that we're going to feel better about making sure we're covering. It also gives our patients a sense that they know how to contact us, and they have this other sense of how to get to us, and that we'll respond back to them. And I think that's something really important. Offices that are doing a fair amount of telehealth have been shown to have a lot less no-show rates, so that you don't have these big gaps that I had 2 patients back-to-back no-show. So it helps kind of really focus in on who you need to see. And you don't have to worry about the 6 feet, and you don't have to worry about all that type of thing. So.
Great, thank you. We have time for one question for Martha from the group. Thank you for addressing the clinical preceptor question too. Appreciate that. Well, I don't see any questions in the chat, so thank you very much, Martha. I appreciate it. All right, so I will, we've got about 10 minutes left, so I will talk about psychiatry and the role of mental health in telehealth. If we run a couple minutes over, those of you totally understand, respectful of your time. If you need to sign off, go ahead. But definitely, we may just run a couple minutes over answering any other questions, and if not, great. All right, so I have my own telehealth business, my own telepsychiatry business. I've got 4 psychiatric mental health nurse practitioners that that work for me, and we serve rural and underserved communities. Psychiatry has kind of been one of the pioneers, along with radiology, in terms of doing telehealth. I personally have been doing telehealth since 2005 when I started it for the Western region of the Army Medical Command when I was active duty Army, and then continued it throughout my career, and then took it with me to both combat deployments in Iraq and Afghanistan. Psychiatry is really built for telehealth. We don't have any, we don't touch patients. We don't really have any kind of skills that we do that would necessitate a live face-to-face in the room visit. And so many psychiatric providers have been doing telehealth, and there's because it's been around for a while, the evidence base there has been able to grow, and research has been done on telehealth visits in psychiatry, and the evidence shows overwhelmingly that it's just as effective, and in many cases sometimes more effective than in-person visits. There is a little bit of, there is a little bit lost in terms of not being in the same room with the individual from a qualitative standpoint, but obviously COVID has changed the rules for all of us. And so many training programs and practices have shifted to the telehealth platforms. One of the things that was mentioned earlier was related to documentation. The way that we document is in our subjective, very similar to what Vicki mentioned, was in our subjective, we document that this was a telehealth visit. The patient was informed of the risks versus benefits to include technology failure, and that they verbally consented to the telehealth visit. And so when I've been, like I said, doing telehealth for a while, one of the things that did change as the pandemic hit for telepsychiatry was that we weren't necessarily always able to see new patients. One of the high risk things that we do is assess for patients' risks. And so if I'm serving a clinic area that's got, you know, 100 square mile radius, I may not always know what zip code that patient is in if I'm seeing them in their home via telehealth, if there's a safety issue. So in other words, what authorities to call, and, you know, those sorts of things if for whatever reason a patient wasn't able to be safe. And so that presented challenges in and of itself is that we had to limit the number of new patients that we saw outside the clinic. The way that my model works for my practice is that we are integrated into these federally qualified health centers and rural health center primary care clinics. So we document in the medical record, the patients come into the clinic, they're seen and roomed and treated just like if they were there for a primary care visit. The only difference is they go to a different room, exam room with a computer screen in there, and then we show up and see the patient, and then the patient checks out and schedules follow-up with us. But when the patients are seen in clinic like that, we've got that safety net to be able to, if there's any safety issues, to make a phone call to the clinic staff and help us make sure that the patient stays safe. When a patient's in their homes, obviously that's different. So we had to adjust our practice to only doing visits in patients' homes and via telephone with known patients. And then our new patients, eventually, once the clinic started reopening again, we were able to start to bring our new patients back into the clinic to be seen. But yeah, it was very, very challenging for that. And then needless to say, that put us behind significantly on the number of referrals. And those of you that have spent any time referring patients for behavioral health services know that the access to care can be months. And so we went from about having a pretty decent access to care of seeing a psychiatric mental health nurse practitioner in about 6 weeks. That doubled to 12 weeks in a matter of really a month. Because we couldn't be bringing, we couldn't bring these patients into clinic because of because of COVID and also being in hotspots and local restrictions and risk to other people and all of those sorts of things. So it was definitely a challenge. But I will tell you, even our older patients and older adults, they have embraced it. I've had one older adult patient in 5 years that said, no, I don't want to do telehealth if they were referred for referral for a telepsychiatry visit. Mainly because we've had that staff support, the staff was able to get them set up and that sort of thing. But we also had to get creative in how we communicated with our patients during the pandemic as well. And so we were having issues with, some staff not always being in on certain days, patients being redirected to voicemails, and we as providers weren't getting messages from our patients that, either needed medication refills, were having medication side effects, or those sorts of things. And so there was just too many points of entry into the clinic, and because they were trying to limit staffing and they can only have so many people in, they were rotating people in, and we were really kind of caught in this workflow abyss, if you will, in terms of trying to set up procedures and policies. And so one of the things that I adopted was a technology that was created by a nurse called Health Talk, like we're talking, Health Talk AI. It's a Health Talk it's an artificial intelligence messaging application that we adopted, and that many federally qualified and rural health centers adopted during COVID in an effort to better communicate with their patients, to be able to provide directives and those sorts of things. And it's a text messaging application that allows the patient to allows us to send out messages to patients. It's HIPAA compliant. Patients don't see other patients' messages. It goes right to their phone, and then they're able to respond back, and they're able to select options for, you know, scheduling a call with me, scheduling a call with my provider, scheduling a call with my administrative assistant and care coordination person at their convenience, and to let us know about medication side effects, to let us know if they need med refills. We give them those options on that text message. And one of the things that you might be thinking is like, oh, that's all well and good, but how many of your patients have smartphones? And we found that about 98% of our patients have smartphones. And we also found that 87% of our patients responded to text messages versus a third of our patients responded to phone calls from us. And so there was this phone tag and all these things that we were playing back and forth with that impaired our communication. We had about, like I said, about 2% of our patients didn't have access to smartphones, so we had to rely on traditional means, you know, phone calls and those sorts of things to communicate with them. But even our older adult populations, many of them had adapted to texting and using online platforms to communicate with family out of necessity. And so we were able to leverage that. And what we found was by using Health Talk, we were able to send them reminders for their appointments. We actually have a video platform that we can do through that they can copy and paste the link and put it into their computer, or we can do visits. They can do a video visit on their cell phone with us. Of course, we talk about, you know, HIPAA and privacy and all those sorts of things. But as Martha mentioned, the HIPAA compliance standards have been relaxed, and that providers are essentially, you know, we use our good judgment, and as long as it's in the spirit of trying to provide care and we're not, you know, overtly directly violating HIPAA, that there is some, you know, that there is some flexibility now, because we know we need to have means of communicating with our patients. So, but Health Talk has decreased my no-show rate from about 9%, which is pretty good for mental health. Generally, it's about 23% in our patient population. My business has pretty much been running at between 9 and 12%, so about 50% less. And there's a lot of reasons for that. The support that we have from the health center, and I won't get into those variables, but there's some things that go into that. But we have decreased that to roughly about 4% since we started using Health Talk, because the patients are getting, you know, text messages and reminders, and they feel like they have more control over when they communicate with us. They don't have to worry about phone tag because they schedule the call with us. They schedule the call with our patient care coordinator to be able to ask for med refills and those sorts of things. So again, even though I've been doing telehealth for so long, you know, the pandemic has caused some changes in how we do business. And I think we've already, you know, talked enough about the billing and those aspects of things, but even just leveraging different technologies and incorporating different technologies into our practice to help facilitate patient communication has really been essential to reaching the patients that we needed. And I'll just throw this out here. Mental Health of America is a national mental health website. They've had an 800% increase in traffic to their website and to their hotline over the last 4 months. And you know, the fact of the matter is that not only are we facing a crisis with the pandemic, but the pandemic is leading to this sequela in terms of, you know, trauma on providers, trauma on individuals, and increased levels of stress and anxiety. And then, oh, by the way, we throw in all the other things that are going on in our country right now, and it's just created a significant amount of stress. I have had more patients in the last 6 months be psychiatrically hospitalized of my panel than I've had in 5 years. And so that really speaks to the acuity of the patients, and also the need and the struggles that they're having, that we've got to be able to adapt, and we've got to be able to communicate with our patients in ways that maybe we're not used to. And it's definitely stepping outside of our our comfort zone. I set myself up with a Google Voice phone number, which was free. It was great. And that's what I use to call the patient. So if they call that number, it goes to my Google Voice and not to my cell phone. I do get the message on my cell phone, but they don't have my cell phone number directly, which is helpful. So for those of you that are worried about confidentiality with patient phone calls, that's certainly a way to do that. So, all right, so that concludes our formal presentation. I want to open it up to any questions from the group. Like I said, I know we're a few minutes over, but more than happy to stick around for another 10 minutes or so and answer any other questions from the audience. And if our panel members could come back on video, that would be great. Yep, *67. Thanks, Nancy. That's another thing you can use. Very practical. Any questions for me or any of our panel members?
I have a question, Jess, for you. And it's Martha. And when we were kind of researching this before, they were saying that some patient population that you're doing that are opiate dependent really are not very good at, we shouldn't probably be using them in telehealth because it holds them accountable when they have to come in, and sometimes patients like that accountability to keep them on the path. Have you found that?
You know, we have really, you know, we've been using it for all of our patients just because from a safety standpoint. I think in the pre-COVID environment certainly makes a lot of sense. But I think, you know, now that we are, you know, obviously in the midst of this, you know, very difficult situation, that we've got to use whatever means, you know, necessary to communicate with the patients. And so we haven't limited our patient type. The only kind of limitation sometimes we have in psychiatry or with our schizophrenic patients that think the TV is talking to them, not appropriate for telehealth. So, but for the most part, we have chosen to see the grand majority of folks, you know, via virtual visits because it's the, you know, because of safety and those sorts of things. But yeah, definitely a great point. I mean, optimally, there is a different level of accountability when they have to come in, when they have to give your analysis, when they have to do those sorts of things. Other questions from the group?
Have you thought about doing mental health telehealth hotline for the staff and our students?
Oh yeah, I mean that's an interesting point. I mean, a part of it is there's a lot of things that go into that, certainly from a liability standpoint. But I think that, you know, we have actually talked about faculty-run practices and things like that. And I don't know if folks remember or not, but we have done some wellness visits and some things like that related to, you know, managing the crisis and stress management and things like that. So I think right now that's within kind of our scope. We'd really have to look at an expansion of our scope and what that looked like to set up that type of a hotline. Great question. All right.
Actually,
you know, go ahead.
Oh, I was going to say, I think it'd be a great thing to explore because of just from the advantage of student clinical site placements, which are only more difficult than ever before. So I'm finding out from, you know, obviously from the RCF point of view and as the student point of view. So faculty practice would be great. I'm glad we're able to do more telehealth.
Yeah, and that's one thing we're struggling with on the psych mental health side is what is that balance between telehealth hours and in-person hours, especially given that students are having a harder time finding clinical placement, and the role of the psych NP in terms of, you know, not having to do physical skills and things like that, where you've got to put your hands on a patient. So, you know, it's something that we're all struggling with, really, in psych NP programs across the country. I've had discussions with about 15 department chairs and program directors across the country about this, as well as our national organization, and there's a lot of varying opinion on that, and so it's going to be interesting to see where that goes. So as far as, you know, those that want to set up a one of the things I didn't mention was, if you are doing telehealth, like for example, I live in Texas, and this is just my soapbox, I won't get licensed in Texas as a psych NP because I don't want to have a collaborative practice agreement. You know, if I was good enough to serve in the military and provide care for our nation's finest, why do I have to work under independently? Why do I have to work with a collaborative practice agreement? That's my soapbox. So unfortunately, I don't see patients in Texas. My patients are in Washington State because it's an independent practice state. And we're seeing that trend with some of the scope of practice issues. So the key thing is that if you're seeing, you have to be licensed in the state that your patients are at, okay? So that's where you have to be licensed. So if you're doing telehealth, or you're setting up a telehealth practice and you're working in 4 states, guess what? You got to be licensed in all 4 states. You got to have DEA numbers in all 4 states. And so those are some things that can be limiting factors. In terms of medical record platforms, was one of the questions I got. It really kind of depends on what you're looking for. There's a lot of tools out there, and I'm certainly more than happy to answer those questions offline if you want to email. So one of the questions that we got is screening, PHQ-9, GAD, and other tools. And so we do use those. We use those electronically so that the patient can fill those out. Most of them have access to, through the medical record applications that we use through Epic and Cerner, where they can communicate with us through the medical record, so they can submit the forms through there. Let me turn that question over to the panel real quickly about, are you all doing that in your primary care screenings and having patients send those back to you electronically? Or is that something that's just not part of the workflow?
No, but that's a great idea, especially with the Edinburgh Postpartum Depression Scale. That would be a terrific thing to do, to send it to them through the portal and have them send it back. That would be, I never even thought about doing it that way. That's great.
I won't say we do it with every patient, but we have done it with patients that need to have it done. And, you know, we can access that through our portal page and have them fill it out, and then it goes right into their chart. So we have done it on specific people, but we're not doing it like, you know, with Medicare patients, like we should be doing all of those things, you know, all of the, what do you call it? Can't think of the word I want.
The behavioral health screens.
Yeah, but it's all the other stuff, you know, that you have to do to meet the guidelines and all that. I can't think of the word. It's too late at night for me to think of the word.
Yeah, we're not doing that at all. Where I'm at, our
HEDIS, that's it. All the HEDIS stuff.
our EMR doesn't have great functionality.
Oh, that's a shame.
Yeah, and again, that's one of those things that we've had to also kind of triage how we, what we include in our visit. And I think that some of the payers, I don't know that necessarily have recognized that. I mean, yeah, there's been flexibility on telephone visits, there's been flexibility on telehealth visits and reimbursement and those sorts of things, but there are limitations, especially if you don't have the capability to do some of these other things that boost up your reimbursement rate. So.
Well, and I think Medicare waived a lot of the HEDIS requirements during COVID because they knew you just couldn't perform. I mean, I can ask somebody, have you fallen in the past, year, and I can ask them if they have advanced directives, which, to document, but, there's a lot of other things you have to do too. And so they waived a lot of that.
Yep. And we're commercial payers usually follow Medicare, but not always, unfortunately. So. All right. Well, thank you all very much for attending our session tonight. A huge thanks to our panel members for joining us and sharing your expertise. And want to wish you all a happy Nurse Practitioners Week. and hope you all have a great week and enjoy the rest of the presentations that we have planned for you. So take care, everybody.
Bye.
Bye.